Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint podcast. All right, welcome to the podcast. Today we have a few interesting questions. This episode is a Q&A episode. All three of us have posted a few times on our social media, and we've had a bunch of questions come through, and we've had a few interesting ones. I have to say, some of the questions are like full episodes worth of questions, and so we're going to do our best to answer what we can, give as much value as we can. But before we get into that, I'll introduce my co-host. So welcome, Giles, to the podcast. How you doing, mate?
I'm good, man. Happy to be here.
And welcome, Luke, to the podcast. How are you doing?
Good, man. Another good week.
And did you have a good weekend? I saw you were at the CrossFit event in Brisbane.
Yeah, it was good, man. Was there for a few hours Saturday, Sunday. Just treating a few people, and then got to wrap up and watch the last few events on Sunday night. See a couple of those crazy athletes punch their tickets to the games, and see the 5-time champ Tia Claire Toomey wrap another one up. So it was good.
Nice. Okay, well, what we're going to do is we're going to start off with the most important question, which is why does Luke look like an Australian Tom Selleck Magnum PI? So who cares to answer that one?
Just tell me, bro, because I tried to look this one up on Google. I'm a 2000s.
Are you telling me you don't know who Tom Selleck is?
No.
Dude, this is just like, this breaks my heart. I'm feeling so old, man. You're going to have, because the geezer's like he's a heartthrob. So trust me, it's a really, really good analogy.
I looked it up. I saw some dude with a fat mustache and a Hawaiian shirt. That's all I got from
That's
it.
Yeah.
You might know
all the girls, man, back in the day.
He was in Magnum PI, he was like the man, but you might know him from Friends. He dated Monica.
Monica's
before Richard and Friends.
That's it. Yeah.
Anyway, he's in a lot of stuff. Like, he is a legend, but I have to say Magnum PI. But you know what? I'm a 90s kid, and I grew up watching the reruns of $6 Million Man, MASH, Knight Rider, and Magnum PI. Magnum PI, man. So I didn't see it in its heyday, but I got to see it all on the repeat, and so I totally get it. I'd stay when I was sick at home from school. I'd just be loving it. So anyway, and then Giles, why are handstands so important for manual therapy?
Oh, because they make you look really cool. And that's the difference between osteopaths and chiropractors, is osteopaths are better looking and we can handstand. That's pretty much it, really.
I'm not going to argue with that. I think this is a good one to start on. Okay. This is from lionheart.performance.lab. And the question is, how are you comfortable selling and charging your worth when you don't have all the answers? Giles, do you want to kick us off?
I don't think anyone has all the answers. Even if you go to the best consultant surgeon in the world, they still don't have all the answers. So I think that's a bit of I understand where you're coming from, but the reality is you're never going to have all of the answers. It's always a working hypothesis. Big thing that I see in manual therapy is people undercharging what they're worth. They are not charging enough. That's a whole topic we could talk about. But the reality is you've done a massive degree, you are qualified, and you are charging less than, sometimes someone who's only done a couple of weeks training course. I think there's a massive issue in people undercharging their value. So I'm a big believer in, I'm always learning. I've written a lot of books, I've written a lot of research. I'm always learning. If I ever get to the point where I think I know everything, I'm going to stop. But I'm also a big believer in charging your worth and having the confidence to do so. So again, I think a lot of it should be in the education at university to go, look, you are qualified medical professionals. You're helping people to get better and get pain-free. You shouldn't be charging peanuts or vouchers or those Groupon deals for like 7 treatments for $3. It makes a mockery of your qualifications, in my opinion.
Yeah, Luke.
Yeah, I agree with that. And like Giles said, if you're undercharging, you're basically just sort of disvaluing what you have to offer. And then all of a sudden you start attracting, a certain type of people, certain type of demographic at the end of the day. And that becomes a whole nother ball game to try to deal and treat with those types of patients, unfortunately. But yeah, at the end of the day, if you're not doing it, someone else will. And there's plenty of people out there that we know that are just scam artists, right? Like, plenty of chiropractors selling things. So, they're better off coming to, a good clinician rather than a poor one. And when it comes to the answers, like it might be referring to, do we have the answers to fix something or treat everything that walks through the door? I guess it's not always about that. It's more rather a process too. So, they're paying for an assessment, a structured plan, evidence-informed decision making from the clinician, your clinical expertise, that entire process along the way of someone's journey, not rather, just to snap your fingers and get someone better in 1 or 2 sessions. So
If you've done the education and what you're pairing with that education is ethical treatment, honesty, proper communication, and you're caring for your patients, you are worth the money you're charging. There are so many people out there that are quacks in our industry that are just doing nonsense types treatments and charging through the roof. So if you are doing that, don't do that. It's just number one. Number two, if you are being honest with your patients and you're providing value and you're being ethical in your approach, you are worth the money you're charging. We need more people like you in our industry. We need more people like you across the globe treating patients. So have confidence in that. And I understand that confidence and insecurities are going to come in different ways throughout your career. That's one thing that I take pride in, is that I'm honest and I'm ethical. And I think that should be the foundation of any good rehab professional. Leading on to another question that's in a similar vein, from the same person, Lionheart.performance.labs. This is a second question, a separate question. What are the biggest mental obstacles to overcome as a rehab professional? Luke, do you want to lead us on that one?
one of the first points I'd probably say is coming to terms and being okay with like very slow and steady progressive rehab in a world where you're on social media, everything seems and comes across as a super quick fix. People are putting out videos, do these 3 best things, do this 1 best thing to fix this type of pain. It's not always as simple as that. So being able to, take someone through a slow and steady progressive rehab phase and adjust accordingly along the way, I think is super valuable and smart. We know with rehab, it's very much individualized. There's not a one size fits all for every single person. So there are going to be adjustments and little tweaks to, their program, dealing with different type of people and personalities that you're going to have to make along the way. So, that's probably one of the main things I would say as well.
And when you talk about mental obstacles, I think the elephant in the room would be imposter syndrome. And we've just discussed this before on the podcast. And I'll get your thoughts in a second, Giles, because I know you've got some good thoughts on this. But I know for me, there's that spectrum between what would be imposter syndrome and then the Dunning-Kruger effect. And you want to be somewhere in the middle of those two things, meaning confident in your treatment and confident and ethical in what you're doing, your communication and your treatment with the patient, but also not at the point where you're assuming you know everything all the time. So it's that difference between confidence and cocky. And it can be a thin line, but an important line of distinction when it comes to our profession or any health profession, because you're treating people. You've got people on your table coming into your clinic that are going to be vulnerable in a place where they need help. And it's really, really important that we're doing our utmost to give them the best treatment, but we're not constantly thinking that we know it all. Both of us know many practitioners, and we see it on social media. There's just this huge rise of people that are just acting like they know everything all the time, this guru era. And that in itself, we know is not true. And that links right back to what you said, Luke. Progressive slow rehab is not wrong, bad, or rehab gone wrong. That's relatively normal. It takes time physiologically for people to heal, to rehab, for collagen fibers to go through their process of remodeling. Things don't happen overnight. And I know that people are selling this quick fix of, I'm going to crack you here, I'm going to rub you here, I'm going to scrape you here, and they have all the confidence in the world. Well, that's Dunning-Kruger, And unfortunately, the person that's going to pay the price for that is not going to be the practitioner, but it's going to be the patient. And I have a real problem with that. So make sure you're good at what you do. Have confidence in terms of the fact that you're ethical and that you know how to communicate care for the patient and you provide a good treatment. But at the same time, every day, find a way to become a little bit better every single day. And what I say to people, they say, well, how do I do that? That's such a general statement. Well, start by practicing your craft a little bit if you're a manual therapist. If you're into rehab like me and Luke, make sure that you're number one prerequisite, make sure that you're going to the gym yourself every day, that you're taking yourself through these biomechanical movements yourself every day. And then another thing is bring out a paper, read an abstract a day if you need to, read a book a month and read a little bit every day. Reach out to people, ask questions on social media, listen to podcasts, have the podcast running while you're on the treadmill, while you're going for a run, while you're doing your sprints. There's so many ways to find value now. It's everywhere. We don't have an excuse. 20, 30, 40 years ago, you'd have to go down to the library. I remember Dr. Locke telling me the story. He would go down to the library, open the books. Giles, you're probably old enough to relate, but you'd have to go and actually look for the information. Now it is everywhere. So there's really no excuse. So try and be better, a little bit better every single day. Be honest, be ethical. And I think that you can be confident in your treatment and you can overcome those obstacles. Giles, any thoughts on this?
To be fair, I think you guys nailed it. I think for me, one of the biggest things is getting over the fact that you shouldn't compare yourself to other practitioners. That's the one thing, massively. Only worry about yourself and don't worry about what other people are doing. Don't compare yourself to other practitioners because they might look like they're having an amazing time and getting amazing results, but half of it's a load of nonsense and half of it's all smoke and mirrors. Get over the fact that you can't treat everyone and everything. Get over the fact that not everyone that's going to walk into your room is going to walk in on crutches and walk out throwing them over their shoulders and doing a cartwheel. The fact is that, you're not going to be able to treat everybody. You're going to have to refer at times. Get over the fact that you're going to be wrong. It is what it is. You are going to be wrong on occasions. Critically think. Don't take it to heart. It's all about a learning excuse. Big thing is leaving the ego at the door, like you guys were saying. That's really, really important. And, being open-minded to change. Critically think, be open-minded to change, not comparing yourself to other people, not comparing yourself to magic quick fixes on social media, and understand that good therapy is boring therapy. Good treatment is dull. There's no magic bozo ball juggling, strap you from the ceiling and spin you around like a pizza party trick. Good therapy takes time. It's dull. It's not Instagram worthy. It's not Facebook worthy, but it works. And stick to really good foundational stuff, and from good foundations build solid buildings. And I think that's a lot of young students are just looking for the easy, quick path. Try not to shortcut it before you know the long way around.
Perfect example I've experienced too is obviously myself and Brogan when chiropractic school, all we were jammed down our throat was, spinal manipulation and adjustments. But coming out into the real world, working with a lot of physios in our clinic, they've taught me a lot of different techniques for spinal mobilizations. Yeah. I found them to be very, very effective. So, when it comes to needing to use something like that on a patient, I will always opt for the safer intervention, see if I can get the change. And then if I can't, sure, maybe a manipulation might be appropriate. But there we go.
You want a book on mobilization? I might have written one. You can rip it off from most PDF pages somewhere.
Yeah, exactly.
So there's plenty of the info out there. You just got to get a hold of it and make sure you're constantly learning, right?
Absolutely right. Absolutely right.
Yeah, it's good. Hey, Giles, I got a question from Scott Patridge, and he's saying, what are you really gaining from IASTM that's different from other manual techniques?
Right. IASTM, instrument-assisted soft tissue manipulation, is not magic. It's useful as a way of saving your hands if you're doing soft tissue work. That's pretty much it. I mean, a lot of people will portray it to have these wonderful mechanisms, but the reality is it follows exactly the same lines as soft tissue work with your hands. If you can rub it with your hands, professionally speaking, you can rub it with an instrument, professionally speaking. The difference a lot of the time is you can apply greater pressure, greater depth without much strain on yourself. For example, use the bars and you can use significant amounts of pressure. It's quite nice for things like scar tissue work and for those sort of areas where you don't want to get your hands in your thumbs. That can be quite challenging because, look, ultimately manual therapy is hard on your hands. It really is hard on your hands. And there's a risk factor to the jobs that we do. We publish research on this. There is a risk factor. A lot of therapists are going to have hand, wrist, elbow, shoulder, neck issues. And if you can use instruments and tools to make your life easier, why not? Some people love it, some people hate it. If it works for the patient, great. But what I would say is don't use it to brutalize your patient and turn them into a tomato, right? You don't induce massive petechia with soft tissue work. Don't induce massive petechia with iastin because it is not therapeutic. It is just capillary damage. So it follows exactly the same lines. And I mean, patients love a bit of kits. Everyone loves a bit of kits. You know what they say, all the gear and no idea. So you pull out a bit of instrument assisted stuff and patients love it. But anything to save your hands and to save your thumbs, man. These should be used for counting money and going on Tinder or whatever dating app you're on.
So it's interesting to note. So you're saying like all manual therapies just generally are going to have a similar neurophysiological outcome, which you can go into more depth and read our research if you want to understand. Because we can't, obviously, this could be a whole episode if we get into depth, but we have really gone in and laid it out in the research between me and Giles and also in Giles's book. So that's there for your reading if you want to. I will just add that a lot of people find there's that difference based on the application of like gliding across the fascial layers, and they have this idea that they're breaking up scar tissue. They have this idea that they're remodeling tissue, which we know is not true. So I'd like to hear your thoughts on that. And number two, I'd like to hear your thoughts on the differentiation between compression, gliding over the fascial layers, versus cupping, which would be a decompression, right? So separating the layers.
All right. So firstly, we're not breaking shit down. I can't be any more simple than that. The only way you're going to break down scar tissue or adhesions if you get a scalpel, knock the person out and slice them open and start hacking away, right? You're not doing it with soft tissue work. You're not doing it with iastin, all right? So we're good on that one. In relation to slide and glide versus decompression, do you know what? Novel stimulus. Some patients absolutely prefer compression. Others much prefer the idea of decompression with cupping. Is one better than the other? Personally, I would say it's what the patient prefers. And if the patient prefers cupping, as long as you're not turning them into an octopus with massive big welts, then I have no issues with it at all. I do find, though, that some of the people that are teaching things like cupping and iastin are overly dramatical in their sort of philosophies. They can create these very, very elaborate thought processes with lots of medical science chucked in. The reality is it's a lot more simple than that. A lot of all manual therapy tends to follow the same lines. We tend to follow the same processes. A lot of it will be down to patient preference, therapist preference. One is not massively superior to the other. Both and all have validity within the treatment process. There is not, look, if cupping was the best thing in the world, we'd all be doing it. If iastin was the best thing in the world, we'd all be doing it. Some people like it, some people don't. So I think we have to be very realistic if that makes sense.
Ultimately, it's this neurological distraction, right? It's this gate theory. Like when you bring it down, when you bring it down to it, it's like this rudimentary version of gate theory, because it's like you're using a stimulus to try and confuse the brain, downregulate pain.
What are you doing? You're inducing a novel stimulus into an area. You're affecting the mechanoreceptors, whether it's through compression, whether it's through decompression, whether it's stretch, that's having a knock-on effect for the other processes. That's going to help you try to reduce tone and improve movement and decrease symptomology. And again, a lot of it, look, some patients absolutely hate cupping. They just hate it. Others love it. Some people hate acupuncture. Other people love it. A lot of it is down to utilizing the correct technique for the correct patient. And as long as you've got decent shared decision-making and the patient has an understanding of the positives and negatives, then I see there's validity in pretty much all things, really.
Yeah, they respond, likely going to respond pretty well to something that they enjoy getting done versus what they don't. Versus, if they're not interested in cupping or anything, likely probably not going to use it. So,
and also bear in mind, there's a massive level of placebo there too, as well.
Yeah.
Placebo-induced analgesia. There's huge amounts of stuff that goes along with that from a psychological perspective.
And also the speed of the conduction based on the myelination or the size of the fibers based on the pain fibers versus what would be touch or proprioception. Like that at a baseline theory, it has a lot to do with it. You know, you hit your thumb with a hammer, you're going to shake your thumb because you're trying to have this novel stimulus to override what would be the pain sensory. And sometimes when it comes to conduction velocities, you can confuse the brain with what would be like deep touch or scraping touch, because that's going to send a variation of sensory input to the brain, which is going to topple on top of what would be the pain input to the brain.
What I would say though is what I don't like seeing is when people are using these types of modalities and they're creating huge levels of trauma, and they're almost highlighting that as a positive, as like a look at me, look at this massive red. And you see this on social media, these poor geezers that have been cupped within an inch of their life, or they've been scraped within an inch of their life, and they're bragging about what they've done to their patients. And they post pictures of their patients with these huge red welts all over their bodies. And I'm just thinking to myself, there's a fine line between treatment and torture. That is not therapeutic. That is just assault. That is brutality, ignorant brutality at best. So I'm all for using these techniques as long as it's done ethically, logically, sensibly, and clinically, and it's not done in prison.
Yeah, if you want that, go run the gauntlet and paintball like I did. You'll come out with welts everywhere.
Well, do you know what? Or do you know what? Give yourself a love bite. You know, yeah, give your patients love bites, because that's what you're doing. It's just, oh my gosh, crazy stuff. So yeah, it's not magic, but it can be a useful tool if you want to save the odd digits.
Oh, so we'll go to the next question, which is from Tatiana Branny PT, and they have asked, how do you tell the difference between osteoarthritis and frozen shoulder? Now, clearly this is a big question, and one that we could go on for a whole episode. Frozen shoulder in itself is a bit of an enigma in terms of, well, it's very misunderstood. Let's put it that way. I'm going to throw to Giles because he's got some interesting takes on it. But before I do that, I'll go through some basics. Both me and Giles have treated frozen shoulder before. Have you done frozen shoulder before, Luke?
I've had a little bit, yeah.
They're not super common, especially depending on the demographic you treat. Like I treat a lot of athletes, so it's not super common. If we do look at some real, like if we zoom out and we look at some real basics between shoulder arthritis and frozen shoulder or adhesive capsulitis, we're going to be seeing a small difference on the age of onset. So shoulder arthritis, usually over the age of 50 with a history of wear and tear or some type of systematic arthritis as well. And then frozen shoulder, we're looking more typically between 40 and 60. And some people say more common in females as well. And that's often what we'd call like idiopathic, which kind of just means like we have no idea. I saw a video actually, and this lady was like, the doctor looked at me and said, it's idiopathic. Which meant that I was both an idiot and yeah, I was both an idiot and pathological.
I saw that.
And I was like, whoa. Anyway, so we're also seeing a difference in pain pattern a lot of the time. And these are generalities, so please don't take them as all for gospel, but it's good to have an idea. Shoulder arthritis, we're looking at, it's going to be worse with activity and load bearing specifically. And it's likely going to get better when you rest it. As in with frozen shoulder, when you rest it, it's kind of going to get more niggly. It's especially going to get worse at night when you're resting it. It's going to get real niggly, and in those moments where it's unprovoked, pain can come up, and that's a real telltale sign. Range of motion is an interesting one, because with OA in the shoulder, you're going to have limited active and passive ROM, but you're likely going to have enough range of motion to do some type of special testing. If you're in the frozen stage of frozen shoulder, you're not going to be able to do much testing. You're going to have like severe loss of both active and passive ROM, but there is a little bit of a differentiation. So with frozen shoulder, you're looking at more external rotation deficits and like a capsular end feel. So when you're like hands-on and you're doing the testing, it does feel a little bit different, as in arthritis is going to feel a little bit more like a mechanical infield. So those differentiations are small, but they can help. The big one is that when you look on, if you get imaging, so with x-rays on shoulder arthritis, you're going to see space narrowing, you're going to see osteophytes, sclerosis, etc. And when you look at an x-ray with someone with frozen shoulder, you're not really going to see those things. So that's a big diagnostic criteria. Onset and cause is going to be a little bit different. So obviously OA is going to be kind of gradual and progressive, and frozen shoulder has 3 distinct phases, and there's varying on what sources you look at. This is pretty much just going to be freezing, frozen, and thawing, to put it basically. And so that's another big way to know if you're not 100% sure. If you're seeing a patient in that freezing, painful stage, that's where I would consider most people get confused with OA. You can treat it conservatively and monitor it, and you're going to eventually see it move into that second phase, and that's going to confirm your diagnosis of FS. And then also crepitus, like you're going to get a little, quite common with OA to have a bit of crepitus, like sounds tendons popping from the shoulder, as you're not likely going to get that with a stiff frozen shoulder. So there is a few diagnostic criterial type things here that I think are helpful. At the end of the day, frozen shoulder is very complicated, very, very complicated. And like I said, I've treated it, and man, it is hard. And one of the most important things I would suggest is that up front you communicate and you educate around it. Those two things are so paramount when it comes to frozen shoulder, and you establish a timeline and you establish the reality of what that timeline is going to be. Giles, your thoughts?
Boom, knocked out the park, man. Yeah, right. So in 2020 they did the Frost trial in the UK, which did a massive review of frozen shoulder or adhesive capsulitis, and it was very interesting because they looked at the different phases. They looked at what sort of people were predominantly being exposed to it. And you're absolutely right. So between 40 and 60 tends to be the age range, with average age around 50. So if the patients are coming in, they're very, very young or they're very, very old, not necessarily, I'm not saying it doesn't happen, but it's very rare that it's going to be a frozen shoulder type issue. Also, if a therapist says they can treat frozen shoulder in 3 sessions, they're a fucking liar, because that is an absolute load of bollocks. So all those magic people that go every 2 seconds, that's an absolute load of codswallop. It is not the case. It is a very, very challenging condition that you have to, as Brogan said, the first thing you do is you lower the patient's expectations. Number one. So if they have true frozen shoulder, you have to lower their expectations to say this could take a very, very long time. Even with good treatment, you can still be hitting 18 months to 24 months. And even years later, there'll be a percentage that will still have symptom issues into the shoulder itself. So it's a very challenging one. And true frozen shoulder, you have true restriction into the shoulder. It's a very difficult one. They've changed it a little bit now. It's the pain dominant phase, stiffness dominant phase, and then the recovery phase. And depending on the phase will depend on what treatments you should be doing. So, for example, in the pain dominant phase, which is in that first 0 to 6 months, it's about symptomology, really. It's about reducing symptoms. Cup it, iastin it, using needling, using soft tissue work, whatever it is you want to do to try to reduce symptomology. And then when you start getting into the second phase, or the stiffness dominant phase, that's when you start getting into external rotation stretching work. You start getting, because of the capsular stiffness, you're trying to decrease that. What I'm not a fan of is manipulation of the shoulder. So I'm not a fan of it if you have that type of condition, because it can be idiopathic, it could be from trauma, it can be systemic. There's multiple reasons why someone could have this. Smashing the shoulder to treat frozen shoulder is not, in my opinion, best practice. And actually the Frost trial don't recommend manipulation. So all this sort of manipulation on anesthetics, not great. The research is not great for it. Mobilization, great. So if you can use things like mobilization work, stretching work, and then when they get into that third phase, that's when you start the recovery phase. And that's all about strengthening and exercise. And it hasn't really got much to do with passive intervention. That's about increasing the range of movement. So again, as you said, it's a difficult one. When you really see it in clinical practice, you know it. It takes a long time, and you are going to see that person for a while. The only way someone can treat frozen shoulder in 3 sessions is if they only have 1 session a year for 3 years. That's the only way they're going to treat it in 3 sessions. So don't buy the bullshit. Good clinical case history, good looking at, and the external rotation, that tends to be the key mover. So is that the first one to go and the last one to come back, if I remember? But yeah, it's a difficult one, and it's very, very challenging.
Brilliant. Luke, do you have anything you want to add on that quickly?
You touched it all, but yeah, I've seen it once. Some guy towards the end of his late 50s, post mobilization, after falling on the shoulder well before he had come and saw me, and he had been to like multiple massage therapists before, and obviously no sort of change. So already he was coming in with having seen other different type of people, so it was difficult to it was a lot of challenge to get those expectations sort of right around it, because he was still after a quick type fix. So yeah.
Yeah, and just I think the important thing to reiterate is don't get down on yourself and don't feel bad. It's going to be a long
Mhm.
process. And I think a lot of
Yeah,
clinicians
exactly.
do that, including myself, man. Like I've treated it and then I'll be like, I'm not getting the results. Like with lower backs, I'm pretty bang on and I get really good results. You know, when with frozen shoulder in the past, it's been frustrating for me because it's a long process and there's no quick fix. And that's not a reflection on your ability or your skills. That's just the reality. And so you have to really base your treatment within reality,
Yeah.
and not be too hard on yourself.
If you're open and honest with your patient at the very start, it has a massive advantageous aspect for the treatment process. If you're not promising them magic and you're not delivering the magic, you're not going to come unstuck. And if you turn around and say, listen, you can do the research yourself, but the timeline is looking like this. If we can get it here, fantastic.
Mm.
But let's be realistic about what we can and can't do.
Okay, so I'm going to throw a question and you've got 30 seconds to answer it, and we're going to close out the session. We've got a few more minutes to go. So we've got a question here. I'll throw you to Luke. How does lifting weights influence you as a clinician?
I guess particularly after years of training, when progress starts to become super slow, um, it makes me realize that rehab can be the same: slow, boring, non-linear. Not always a quick fix too. So that's easy to relate to the patient with that. Overall, we touched on it in the previous episode. Fit for practice makes me feel good training, practicing what I preach as well, teaching people how to move, building strength, navigating and combating certain injuries. All things that I'm doing myself in my own training, so it's easy to relate on that perspective. You also gain, self-reflection, coaching experience, particularly if you're working with a coach in whatever sport that may be. So for myself, weightlifting helps transfer those types of coaching qualities over to your consultations and rehab approach with patients as well. And it's a good way to be able to understand how to modify patient programming. So load, volume, frequency, all things that I need to do constantly in my own programming, especially when you're going through different building phases and volume blocks and leading up to competition, knowing when to taper off, when to deload. There's plenty of people out there that say, you should, if you're not training, like you shouldn't really need to deload. But in my opinion, it's like you're not really training hard enough. But yeah, and then especially when they're carrying an injury as well, you want to be able to modify all of that so they can continue to do some sort of movement and exercise without prescribing them, just complete rest and activity.
That's good. That's good. There's a question here on the importance of isometrics. So I'll take that real quick. Obviously, I'm a big fan of isometrics. I've talked about it on the podcast. I've also talked about it on our channel. A lot of people are kind of almost hating on isometrics, especially when it comes to tendons. So it's almost like they're kind of like reversing back on them, because I know a lot of people are like, you have to start with isometrics. You don't have to start with isometric when it comes to a tendon issue. You have to treat the patient where they're at. Let's be clear with that. However, there is some research, Ebony Rio out of Australia, that shows that it can have an analgesic effect. It can have a pain reducing effect when you apply an isometric on a true tendon issue. If it's not a true tendon problem, it's not going to have that effect. So people go, well, it doesn't work for me and my patients. Well, is your diagnostic criteria accurate? Are you correctly identifying a tendinopathy? That's what I would ask. Isometrics are very effective when they're used at the right time for the right person. Even if it's not a tendon problem or if it's any type of rehab, it is going to be less provocative by nature, for the very fact that it is a safe and a static type of contraction. Now, I'll also say that although the muscles are static, you're still getting fascicle gliding with the isometric for the tendon. So it's great, safe, static way for loading tendons that are still going to promote fascicle gliding and is not going to be provoking the tendon, as they can be easily provoked through compression and rapid motion and loading and reloading, etc. So across the board, it just makes sense. I think it's also very common sense when it comes to the fact that if you're trying to rehab, isometrics is going to be a safe way to start. But it's not just that for rehab, that also can be beneficial for performance. In fact, there is a research study that looked at isometric contrast training versus dynamic contrast training, and it actually outperformed dynamic contrast training with faster 10-meter and faster 20-meter sprints and a larger standing long jump. So it's actually understanding that isometrics are more than just, they're not a quick fix, but they are enhancing neural drive, increasing tendon stiffness, and able to actually produce explosive force in some demographics of athletes. And we've seen that in some research. So don't dog on isometrics, just like isotonics, just like slow, steady, progressive loading. They are a tool to be used for the right person at the right time. Giles, we've got a question here from Scott Partridge. He's saying, has the term rehab gained a negative connotation and should we look to rebrand it?
I would say no. It's fine. Don't worry about it. There you go.
Beautiful. And Luke, in 30 seconds or less, do you want to comment on the epidemic of back pain and the inconsistent support provided by professionals?
Briefly, I had a point that I wanted to touch on with the inconsistent support is with how much time we got? 30 seconds?
No,
there is no unified standard of care for low back pain. So if you compare it to something like a medical condition like diabetes, there are treatments and protocols set in place. So currently, why there's a lack of support is in back pain. You could go to a chiropractor who blames it on joint alignment. You could go to a physio who blames it on tight muscles. You could go to a surgeon who wants to cut every patient open, and a GP who wants to tell you to take painkillers. So there are all different ways to approach this. This is why patients get told different things by different people.
Yeah, people are very out of date. There's a lot of information. There's recency bias with research. People think that new research is better. It's not necessarily better. There's a whole thing. It's a whole episode on itself. Thank you for listening to the episode. It has been fantastic. We'll do a Q&A again. As always, make sure that you check out the rest of our episodes. Thanks for your time, Giles. Thanks for your time, Luke. Have a fantastic rest of your week, and we will see you next week. See you, lads. Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint podcast.